Welcome to Chapter 2, Lesson 2 of HIT 255. In this chapter, we will be discussing clinical coding and coding compliance. The objectives of this chapter are to differentiate the different code sets that are approved by HIPAA, to describe the structure of approved code sets, and lastly, to examine coding compliance issues that influence reimbursement. As we talked about in Chapter 1, reimbursement is really the payment to healthcare providers and/or facilities for services that were rendered to the patients. Communication of these services is transmitted from providers to third-party payers. Remember, those are like insurance companies, via coded information. So this slide really stresses the importance of coding. If coding is your program, or you want to be a coder and you're in the HIT program, this really drives home the point of how important coding is. You are the drivers of reimbursement in healthcare. Sequencing incorrectly, assigning the wrong codes can have a huge impact on reimbursement. We want to make sure and follow all the guidelines, the official coding guidelines. So what does coded information do? It allows for consistent communication between the third-party payer and the provider, and it also allows for an efficient payment process method. These code sets are used to transmit health services in a standardized format via the HIPAA Act of 1996. Physicians and healthcare facilities will receive accurate reimbursement for the services that they provide to patients only if the claims submitted comply with the guidelines and the conventions published by HIPAA. What code sets does HIPAA approve on the claim forms? This includes ICD-9 codes, CPT codes, and also HCPCS Level 2 codes. No other code sets are acceptable to be submitted on the claim forms. ICD-10 codes will be accepted in the near future. So, the people that deal with claim forms and dealing with third-party payers on the physician side have to have at least a basic understanding of all those different code sets that we just mentioned to fully understand the prospective payment system, not only for Medicare, but for other insurance companies as well. All physicians and healthcare facilities must comply with the guidelines and rules published for each approved code set. ICD is the International Classification of Diseases. As you probably know from your coding courses, this is maintained by the World Health Organization. It's used throughout the world for mortality, and it's updated about every 10 years, or is supposed to be updated every 10 years. ICD-10 is used in other countries. It is not implemented in the United States yet. The date on this slide lists October 2013 that ICD-10 will be implemented. That is incorrect. That was pushed back to October of 2014. ICD-9 is the coding system that many of you have probably learned, or those of you that are already in the field are probably very familiar with ICD-9. This is the 9th revision. This is the system that we are currently using in the United States to assign codes that go on the claim forms that then go to health insurance or third-party payers. What is happening with ICD-9 is really we're out of codes, we're out of room to expand. New diseases are being found every day. So, really we need to expand upon the system, and we're out of room in the ICD-9 classification. And also ICD-10 is used in other countries. What are the uses? We can classify diseases and death for statistics. Again, this is a really solidifying the importance of the coder in a medical facility. The data that you code not only is used for reimbursement to the medical facility, but also for statistical purposes used by the facility, by the state, and by the U.S. in general. ICD-9 codes are used for Medicare prospective payment systems. The MSDRG groups are based on ICD-9 coding. If you've taken coding, this is again a review. Volume 1 is our tabular list of diseases. Volume 2 is our alphabetic index to diseases. And we have to remember that we cannot just code from one or the other in this ICD-9-CM for diagnosis coding. Volume 3 is our procedure index. Our codes are from 2 to 4 digits for the procedures. This, if you've taken an I-10 class, these codes, especially for the procedures, are drastically different. ICD-9 is updated every year. Occasionally it will be updated twice a year to reflect new codes, changes in the coding, the wording. They delete codes, that kind of thing, but really no significant changes will happen in 2013 because of the impending ICD-10 implementation. The coding guidelines are critical for anyone in our profession to know where to locate and understand whether you're doing coding, whether you're a director. It's very important, if you don't have those memorized, to at least know where to go to find those. HCPCS stands for Healthcare Common Procedure Coding System. We have 3 different levels, which we'll talk about. Level 1, 2, and 3. Level 1 codes are Current Procedural Terminology, or CPT codes. These report diagnostic and surgical procedures and services. These were created and published by the AMA in 1966. We're now in the 4th version of CPT. So these are used for outpatient services, procedures only. The diagnosis portion of outpatient procedures is still assigned with ICD-9 Volume 1 and 2 codes. Who uses CPT codes? Well, as I said, any ambulatory or outpatient procedure is assigned a HCPCS code. What is in the CPT book? Category 1 codes are really the bulk of the CPT book, and the modifiers. So we have E&M codes, that's your charge for seeing physicians, that's a physician charge, your surgery, radiology, path and lab, and medicine. Category 1 codes are consistent with contemporary practice and performed by physicians in multiple locations. There are 5 digits, and they cover surgeries, procedures, and services like pathology and laboratory. These codes facilitate data collection for services or test results that contribute to positive health outcomes and help improve the quality of health care. Category 3 codes represent emerging technology, so new services that are being offered. These are always reported rather than an unlisted CPT code if they are available. These are also a 5-digit numeric, alphanumeric. These are all the bodies that help maintain the CPT system. Where can we look to find CPT official coding guidelines? The American Medical Association publishes these guidelines and also advice such as similar to the coding clinic, but in the CPT side, it's called CPT Assistant. HCPCS was created in 1983 and developed by the CMS. These are alphanumeric codes with the exclusion of S. They represent services and supplies that are not included in CPT, such as durable medical equipment. Things like wheelchair, splint, casting materials, and the like. In HCPCS, there are permanent and there are temporary codes. If they are temporary, they will then possibly be moved into permanent CPT codes. This I like to think of as more of a trial period, and they're gathering data to see how often this code is used. HCPCS is also maintained just like any other coding system. The permanent codes are updated every year. Temporary codes updated every quarter, so they're evaluated a little more often. And here too, we're going to turn to the American Hospital Association for advice on coding HCPCS codes. A modifier is a two-digit numeric, alphanumeric, or alpha character that's recorded with a HCPCS code, level 1 and 2 only. Basically, what a modifier does is flag a code to say that it is different or special in some way. Some examples of when we may use a modifier: if a service has been increased or reduced, if only part of the service is done, if a bilateral procedure is done, if anything unusual occurred during that procedure. Those are just some of the many examples when a modifier usage may be appropriate. How do we determine when it is appropriate to use a modifier? We obviously have to go back and look at the documentation. If there is not documentation to support use of a modifier, one should not be applied. These are some examples of modifiers. Again, if you've taken CPT, you have the book, you can look at the list is much greater than what is here. These are just some of the examples. What is coding compliance? Well, compliance is performing one's job function according to the laws, the regulations, and the guidelines that are set forth by Medicare and all the other third-party payers that are out there. AHIMA does publish a standards of ethical coding. Those are the rules that you as someone in coding or billing or anyone who deals with reimbursement should be following. When we talk about coding compliance, we have to define what's fraud and what's abuse. Because if your hospital is audited, this will be one of the first things that they will try to determine. Did you do this on purpose, or was it an honest mistake? So fraud is intentionally knowing something is false and doing it anyway. So if you know that it is inappropriate to assign a particular code as the principal diagnosis because it will land in a higher DRG, but you do it anyway, maybe the physician has said to or someone has told you to, either way, you know that that was wrong and you did it anyway. So that is determined fraud. Abuse, on the other hand, is really what they say is a mistake. Generally, if they come in and determine that it was abuse, you were coding and submitting claims to the best of your knowledge, you really felt everything was submitted appropriately, maybe you just didn't know, a slap on the wrist, don't do that again, basically is what will happen. And you then, as the coding compliance manager, the director, the coding supervisor, whoever you may be that is responsible, you will then have to disseminate that information and make sure anyone coding knows what the audit was, what do we need to fix and not see happen again. There's also laws that come into play with coding compliance. One is the False Claims Act. What this does is basically prohibits knowingly filing a false or fraudulent claim in order to get payment from a government third-party payer. So again, that falls under fraud. You know it was wrong. Conspiring to defraud the government by getting a false claim, you will be penalized for that. You've probably heard cases on the news, people submitting claims that for services that were not provided, or they're billing for 5 of the service instead of 1. There's all kinds of examples, and I seem to catch things on the news every so often in regard to people submitting false claims. Here are some examples. One, an unlicensed physician used the provider numbers of other physicians without them knowing to bill for Medicare for services that were not performed. The doctor pled guilty to money laundering and filing those false claims. He was sentenced to 18 months in prison and required to pay the government back, and probably in excess of what he had billed. The Civil False Claims Act, this basically is the whistleblowing. Refers to someone who told the government, hey, I worked for XYZ clinic and I know they were submitting false claims. So this helps protect those whistleblowers. If you are the coding compliance manager or you work at all in coding compliance, it is very important to look at the OIG's compliance program, and that really should structure the coding compliance program in your healthcare organization. You must have written procedures, policies. You must state who your compliance officer is. How do you provide education and training to those that are involved in coding and billing? How is that information communicated? A new coding clinic is published. How does that get communicated to all the coders? Who audits? Is it the coding supervisor? Do you do peer auditing? One coder audits the other, and so forth. And what happens if you notice incorrect coding? Do you correct it? Do you discipline the coder? How does that happen? All of those things must be outlined in a written policy and procedure. A website you may want to bookmark is the OIG website. This is an organization that will come knocking on your door if they suspect fraud. So the Supplementary Compliance Program Guidance for Hospitals. This just really outlines the risk areas that are out there and how that will affect your coding compliance program. The Operation Restore Trust is a joint effort between the DHHS, OIG, CMS, and the AOA, and really what they're looking for is targeting fraud and abuse. There is 5 focus states. California is one of those states. Within the first 2 years of that program, they spent $7.9 million, but they got back in fraudulent claims or claims that were not, whether they were upcoded with abuse or fraud, whatever it may be, they were able to recover $188 million. As part of that act, there is a national toll-free fraud and abuse hotline, whether you're a patient that suspects your bills are incorrect, whether you're an employee that knows something not quite right is going on. The HIPAA Act of 1996, a large portion of that act was focused and targeted on picking out fraud and abuse and trying to correct some of the fraud and abuse that is happening today in the U.S. They looked at things like medical necessity. Did we need that lab or x-ray performed depending on our diagnosis? Upcoding, unbundling, billing CPT codes separately that really should be together and just build one. And then obviously billing for things that were not even done in the first place. The definition of upcoding and unbundling are listed here. You can read through those and also read through in your textbook as well. What HIPAA did is to mandate fraud and abuse control programs. One of those was the Medicare Integrity Program. They looked at payment determinations, audit reports, education for providers, and also for beneficiaries on what is fraud, what is abuse, how can we prevent that. The Balanced Budget Act of '97 was one act that was trying to improve program integrity. So notifying beneficiaries that they could request a copy of the bill for their health care services. Telling beneficiaries or patients that they should look at their EOB, make sure that they actually receive the services that were billed, and then of course a toll-free hotline for fraud and abuse. Quality improvement organizations are organizations that contract with Medicare to monitor hospital performance on a state or regional basis. These are guided by scope of work. Each scope of work will last 3 years, and every scope of work has a different focus. The current scope of work is the 9th, and what they're looking at now is protecting the beneficiaries or the patients, patient safety. There's a lot of medical errors that happen in healthcare organizations, so preventing those as well. The 6th scope of work was the PEP. This was, as I said, the 6th scope of work, but most payment errors they found were caused by simple mistakes that were not fraud and not abuse. They were just simple mistakes. So the coder really truly thought that they were coding correctly. The patients were transferred when they shouldn't have been, things like that. The 7th scope of work, which was the hospital monitoring program, this replaced the PEP program, looked at one-day stays, same-day readmissions, case mix index creep up, and DRG relationship. Recovery Audit Contractors, or RACs, were implemented as part of the MMA 2003. They called for a demonstration project, and they wanted to look at those claims again, look at fraud and abuse, and try to recover some of the dollars that were awarded when they should not have been. So they were looking at underpayments and overpayments for Part A and Part B claims, so inpatient and out. During the first year of the RAC program, they were able to recover $54.1 million that they had overpaid providers. So that is a huge chunk of money for that program. What did we learn from the RAC program? A lot of improper payments were happening. Providers did not appeal every overpayment, but they were allowed to do so. The RACs were willing to spend time educating providers, developing relationships, and really helping the organizations to be billing more appropriately. The RAC is now a permanent program, so they'll be focusing on the same things they were initially, and each RAC must hire a physician medical director as well as certified coders. So you may want to research in your area and see if there is a RAC near you. This would be a great place of employment. These are things that must also be included in your policies and procedures in your compliance plan. How are you going to query physicians? Who can query? Who cannot? Can every coder ask any physician anything? How will you handle upcoding, unbundling, incorrect use of the encoding software? What kind of training is available on that? Education and training really needs to be a big part of your coding compliance plan. How will you disseminate new information that comes in the form of LCDs, NCDs, new coding guidelines, new coding changes, the OIG work plan. So all of those things have to be incorporated in your coding compliance plan. And as we talked about before, you need to have documented who will audit, how often will you audit, will you just look at internal benchmarking, or will you look at what other hospitals are doing as well. And then you should, if you have not already, please go through in your Chapter 2 of your textbook and look at some of the examples that are provided there for you.